I feel honored as part of a larger team. I just want to reflect that I'm one of many, including people like Phil Nader from UCSD and Sharon Hillage from our school district in Chula Vista, Cheryl Motor from the County Obesity Initiative, our Health and Human Services partners, Eric McDonald and Elena Quintanara, and many other community partners that have made our collaborative in San Diego successful. Next slide, please. I would like to begin our discussion with this diagram, which demonstrates a framework for the complex interactions of a systems approach. So I want to talk about what is meant by a systems approach. This is when strategies focus on interactions between different sectors in the community and between the individuals and their environment. Secondly, a systems approach accounts for the context and characteristics of a community in planning strategies. This allows unintended consequences of intervention strategies to be immediately recognized and altered if required. As an example, early in our collaborative work, we attempted to do healthy weight assessments and plans with families at a large school event. However, we discovered that this was not a location that allowed for individual BMI measurement and goal setting due to a lack of privacy and excessive competing activities. Thirdly, in this systems approach, it utilizes a multidisciplinary strategy that is feasible, sustainable, and scalable with reach across cultural and language population subgroups. A systems approach is different from a multi-level or sectored approach. Next slide, please. San Diego Healthy Weight Collaborative implemented several key strategies as outlined here. Today I will focus on key learnings from our second strategy, disseminating a healthy weight message across multiple sectors, as well as our fourth strategy, implementing policy changes. We have further details in our publication that can be referred to in the Journal of Healthcare for the Poor and Underserved in May this year. Next slide, please. This slide identifies just so many partners involved in our collaborative that include the public health, primary care sector, schools, community organizations, and promotores who represent our community. There was no budget at the beginning of our collaborative, so it required a commitment of resources from each of the agencies. Aligning the work plans of individual agencies with the collaborative helped to ensure sustainability. It was important to track from the beginning any data such as meeting minutes, chart reviews, surveys, BMI measurements, in the effort to help us evaluate our collaborative. Next slide. Our work focused on a definable and specific region. We chose 3 sites that represent a population of over 8,800 and included a community clinic, an elementary school, and an early childhood center. All are located within a few blocks from each other in southern San Diego, 7 miles north of the border crossing into Mexico. Our team reviewed available data to characterize our target community, a predominantly Latino and low socioeconomic population. We were fortunate to have data from the Chula Vista Elementary School District 2010 BMI surveillance project that measured over 25,000 students. Our target school was shown to have obesity rates of 28%. But when overweight students were added, it raised the total number of students with an unhealthy weight to 44%. As you can see in the chart, other obesity data was not as readily available. Next slide, please. This is a complicated strategy map that represents how our collaborative used systems thinking as a tool to design our interventions. Central to our plan in the blue circle is the target population, surrounded by 5 large boxes that frame our overall strategies. Within each strategy, there are 5 color-coded sectors representing primary care, public health, schools, community, and early childhood. Team members actively participated in each of the strategies, and we constantly looked for new ways to develop interactions between the different sectors. Key to this process was ensuring that parents and kids would be impacted in each strategy. We also looked at what data could be collected and how to measure our impact with the resources available to us. Next slide. To disseminate a healthy weight message, our team reviewed the literature and selected 5210 from Portland, Maine. We considered language and cultural factors in translating our message by eliciting input through focus groups at each of the 3 target sites that included staff, parents, students, physicians, and teachers. We created a variety of bilingual materials with the healthy weight message to place at multiple sites to reach our target population. Bilingual posters pictured here included all 17 logos from the collaborative. On the right side, the clinic received bilingual prescription pads that we adapted from the American Academy of Pediatrics, as well as other health education materials. We disseminated with staff trainings to help consistently incorporate the materials into workflow. Quality improvement was monitored through the year-long process reviewing charts. We supported school and child care classroom activities and school-wide events that focused on 5210 and wellness that included students, staff, parents, and our Healthy Weight Collaborative team. This helped to link the work in the clinic with the work in the community outside the walls of the clinic.